Chronic pyelonephritis. Chronic pyelonephritis is a disorder in which chronic tubulointerstitial inflammation and scarring involve the calyces and pelvis. Two types of chronic pyelonephritis are reflux nephropathy and obstructive pyelonephritis. First, reflux nephropathy. Reflux of urine from the bladder into one or both the ureters during maturation is the major cause of chronic pyelonephritis. Vesicoureteric reflux. It is particularly common in children, especially in the girls, due to congenital absence or shortening of the intravesical portion of the ureter, so that ureter is not compressed during the act of maturation. Reflux results in increase in pressure in the renal pelvis, so that the urine is forced into renal tubules, which is eventually followed by damage to the kidney and scar formation. Obstructive pyelonephritis. Obstruction to the outflow of urine at different levels predisposes the kidney to infection. Recurrent episodes of such obstruction and infection results in renal damage and scarring. Morphology. Grossly, the kidneys show rather characteristic appearance. The kidneys are usually small and contracted, that is weighing less than 100 grams, showing unequal reduction, which distinguishes it from other forms of contracted kidney. The surface of the kidney is irregularly scarred. The capsule can be stripped off, but with difficulty due to adherence of to scars. These scars are of variable size and show characteristic U-shaped depressions on the cortical surface. Microscopically, in interstitial, there is chronic interstitial inflammatory reaction, chiefly composed of lymphocytes, plasma cells, and macrophages with pronounced interstitial fibrosis. Tubules. The tubules show varying degree of atrophy and dilatation. Dilated tubules may contain eosinophilic colloid cast, producing thyroidization of tubules. A few tubules may contain neutrophils. Pelvic calyceal system. The renal pelvis and calyces are dilated. The walls of pelvis and calyces show marked chronic inflammation and fibrosis. Lymphoid follicles with germinal centers may be present in the pelvic calyceal walls. The lining epithelium may undergo squamous metaplastic change. Blood vessels, changes in blood vessels. Blood vessels entrapped in the scarred areas show obliterative endarteritis. There may be changes of hypertensive hyaline arteriosclerosis, changes in the glomeruli. The glomerulus in the scarred area is usually intact. There is often periglomerular fibrosis. Now, the effects of hypertension on kidney is very important. Benign nephrosclerosis and malignant nephrosclerosis. Benign nephrosclerosis is the term used to describe the kidney of benign phase of hypertension. Mild benign nephrosclerosis is the most common form of renal disease in persons over 60 years of age. Whereas malignant nephrosclerosis is the form of renal disease that occurs in malignant or accelerated hypertension. Malignant nephrosclerosis is uncommon and usually occurs as a superimposed complication in 5% cases of pre-existing benign essential hypertension disease, or in those having secondary hypertension with identifiable cause, such as in chronic renal diseases. The morphological features: benign nephrosclerosis, grossly, both the kidneys are affected equally and are reduced in size and weight, often weighing about 100 grams or less. The capsule is often adherent to the cortical surface. The surface of the kidney is finely granular and shows V-shaped areas of scar. The cut surface shows firm kidney and narrowed cortex. Vascular changes. Changes in blood vessels involves arterioles and arteries up to the size of arcuate artery. There are two types of changes in these blood vessels. Number one, hyaline arteriosclerosis that results in homogeneous and eosinophilic thickening of the wall of small blood vessels. Number two, intimal thickening due to proliferation of small muscle cells in the intima. Now, what are the parenchymal changes? As a consequence of ischemia, there is variable degree of atrophy of parenchyma. That is, parenchyma gets atrophied. This includes number one, glomerular shrinkage. Glomerular shrinks in size. Number two, deposition of collagen in the Bowman's capsule, this co-space, giving a eosinophilic color on microscopy, light microscopy. Periglomerular fibrosis. Fourth, tubular atrophy. And fifth one is fine interstitial fibrosis. Now, what are the changes seen in the malignant nephrosclerosis? First, we will discuss about the gross features, then thereafter vascular features. Grossly, in case of malignant hypertension, superimposed on pre-existing benign nephrosclerosis, the kidneys are small in size, reduced in weight, and have finely granular surface. However, the kidneys of patient who develops malignant hypertension in pure form are enlarged, small, enlarged, edematous, and have petechial hemorrhages. Because of these petechial hemorrhages on the surface, the characteristic appearance of kidney is called as flea-bitten kidney. Cut surface shows red and yellow mottled appearance. When we talk about vascular changes, these are more severe as compared to benign nephrosclerosis and involving the arterioles. The two characteristic vascular changes which are seen are as under: necrotizing arteriolitis develops on the hyaline arteriosclerosis. The vessel wall shows fibrinoid necrosis. That's a very characteristic example of fibrinoid necrosis. A few acute inflammatory cells and small hemorrhages. Hyperplastic intimal sclerosis or onion skin proliferation is characterized by concentric lining of proliferated smooth muscle cells, collagen, and basement membranes. Ischemic changes. The effects of vascular narrowing on the parenchyma include tubular loss, fine interstitial fibrosis, and foci of infarction necrosis. Renal cell carcinoma शुरू कर दिया मैंने. Renal cell carcinoma epidemiology. Tobacco is the most significant risk factor. Cigarette smokers have double the incidence of renal cell carcinoma, and pipe and cigar smokers are also more susceptible. Other risk factors include obesity, particularly in women, hypertension, unopposed estrogen therapy, exposure to asbestos, petroleum products, and heavy metals. Most renal cancer is sporadic and involves the arterioles, but unusual form of autosomal dominant. Most renal cancer is sporadic. Most renal cancer is sporadic, but unusual forms of autosomal dominant familial cancers occur, usually accounts for about 4 to 5% of cases. Von Hippel-Lindau disease. It is an autosomal dominant cancer syndrome that includes hemangioblastoma of the cerebellum, along with retinal angiomas, multiple renal cell carcinoma, clear cell type, pheochromocytoma and cysts in different organs. Patients of VHL disease have germline mutations of tumor suppressor VHL gene located on the chromosome 3p, commonly as homozygous loss of VHL gene. Hereditary clear cell RCC. These are cases of clear cell type renal cell carcinoma confined to the kidney without other manifestations of VHL, but having autosomal dominant inheritance. Papillary RCC. This form of RCC is characterized by bilateral and multifocal cancer with papillary growth. Genetic abnormality in these cases lies in MET gene located on the chromosome 7. Chromophobe RCC. These cases have genetic defects in the form of multiple losses of all chromosomes, that is, they have extreme degree of hyperequality. Morphologically, grossly, the RCC commonly arises from the poles of kidney as a solitary and unilateral tumor, more often in the upper pole. The tumor is generally large, golden yellow, and circumscribed. Papillary tumors have grossly visible papillae and may be multifocal. About 1% RCC are bilateral. Cut section of the tumor commonly shows large areas of clear cell type RCCs. This is most common pattern, constitutes 70% of the cases. The clear cytoplasm of tumor cells is due to removal of glycogen and lipid from the cytoplasm during processing of tissues. The tumor cells have a variety of patterns: solid, trabecular, and tubular, separated by delicate musculature. Majority of clear cell tumors are well differentiated. Papillary type RCC seen in 15% of the cases. The tumor cells are arranged in papillary pattern over the fibromuscular stalks. The tumor cells are cuboidal with small round nuclei. Several bodies may be seen. Chromophobe type RCC, 5% of cases. This type shows admixture of 12 clear cells with perinuclear halo and acidophilic granular cells. The cytoplasm of these tumor cells contains many vesicles. Wilms tumor, also known as neuroblastoma. It is an embryonic tumor derived from primitive renal epithelium as well as mesenchymal components. It is the most common abdominal malignant tumor of young children, seen most commonly between 1 to 6 years of age with equal sex antigens. Wilms tumor has following etiologic associations: a defect in chromosome 11p13 results in abnormal growth of metanephric blastema without differentiation into normal tubules and globuli. A higher incidence has been seen in monozygotic twins and cases with family history. Association of Wilms tumor with some other congenital anomalies has been observed, especially of the genitourinary tract. A few other malignancies are known to have higher incidence of Wilms tumor. These include osteosarcoma, Botrytis sarcoma, retinoblastoma, neuroblastoma, etc. Grossly, Wilms tumor tends to present as a large, solitary, pale circumscribed mass Approximately 10% are either bilateral or multicentric at the time of diagnosis. On cut section, the tumor is soft, homogeneous, and tend to gray with occasional foci of hemorrhage, cyst formation, and necrosis. Microscopically, the classic triphasic combination of blastomal, stromal, and epithelial cell type is observed in the vast majority of lesions, although the percentage of each component is variable. Sheets of small blue cells, few distinctive features characterize the blastomal component. Epithelial differentiation is usually in the form of abortive tubules or glomeruli. Stromal cells are usually fibroblastic or myxoid in nature, although skeletal muscle differentiation is not uncommon.